So the next talk will be Professor Dr. Vijay Krishnan. To chair this session, I request Professor Ravi sir, Professor C.R.K. Balaji sir, and Professor Krishna Sundari madam.
Good afternoon, friends. At the outset, I would like to thank and congratulate Dr. Shankar for organizing this wonderful conference, edition 2.0. We all know how difficult to organize a conference at this era, and doing 1.1 is difficult, and rather difficult is 2.0. I would like to place my sincere thanks to him for doing this wonderful program under IASSA. Respected chairperson, distinguished faculty, and dear colleagues, nobody likes surgical failure. I am sure every one of us here would have faced some kind of failure in our surgeries practice. Yet, every surgeon who treats OSA will eventually encounter if you have done enough number of surgeries. These patients should not be viewed as surgical failure. Instead, we should look at them as the opportunity to learn more why the case failed, why the surgery failed. Before discussing revision surgery, let us understand why this topic has been increasingly relevant. Today, nearly 1 billion adults worldwide suffer from OSA. Surgical techniques have evolved, not only techniques, evaluation aspect, but still we face failure. That's what we were talking in the previous lecture about how pediatric OSA surgical failure happens and how to solve them. In most cases, the failure is not due to poor surgical technique alone. Sometimes it is because our own decision making. Let us see how we have to structurally evaluate this patient. These are all complex OSA patients. Whenever a patient presents after a failed surgery, I believe there are 5 fundamental questions we have to ask. First question not to think about is where the obstruction. That will narrow down your mind that it is purely because of anatomical obstruction. The first question should be, why did the surgery fail? How should I reassess this patient? Which investigation will truly change my decision making? Whether this patient really need the next surgical intervention or non-surgical intervention. And if we have to choose the next surgical option, how do I individualize the treatment instead of straight away jumping into another surgery? That's where the precision medicine and what we were talking about this from the morning. In this transformation from the era of UPPP to precision medicine, we have seen a lot of changes. The real paradigm shift came with DISE and dynamic MRI, where we could see the dynamic collapse happening in the airway. Not only that, the reformation or redirection of the muscles, where we could preserve structures, preserve the function rather than destructive excision. Before we discuss failure, we must first define success. For many years, we know the traditional Sher criteria, where a 50% reduction in AHI and a post-operative AHI below 20 was considered successful. In that scenario, if a patient's AHI from 50 to 18 is considered successful, but from 20 to 8 may not be successful. Therefore, the success is not defined just by numbers. We should look at other aspects like symptom resolution, hypoxic burden, which had a wonderful talk by Dr. Vignesh, cardiovascular risk reduction, and significant patient factorial improvement. That's what we call it as functional success. We have to look at patient's perspective, not just repeated or post-op PSG. The next thing is about, is the patient is really a failure? That's where the categorization comes. Whether we are going to name him as a persistent OSA patient, that means there is no improvement after surgery, or a residual OSA, the AHA must have reduced from 100 to 50 or 50 to 20, that means it is residual OSA, or the 50 would have become 5 and then again it would have become 20, that is recurrent OSA, that is reappearance of disease after an initial period of successful treatment. So distinguishing these three categories is extremely important, because each has its own way of managing. Here we have to understand the multifactorial cause for the failure. Of course, patient factor is most important. Other than that, we have to understand that OSA is a metabolic syndrome. It affects not just the upper airway, it affects the entire body. That's where we were talking about the morning, about all these biomarkers and systemic inflammation markers. In reality, surgery rarely fails because of one single reason. The important factor here is obesity, which is one of the primary modifiable factor of recurrent OSA. All this fat deposition, biomechanical change, metabolic interaction, weight gain, all could have been sorted out if we could control OSA, because it is all intercycle. Both are interrelated. OSA induces obesity, obesity causes OSA. And this is one single most important modifiable factor in recurrent OSA. Aging, of course, contributes in a similar way. That's where more than 60 years you have to have a red flag before doing any surgery on this patient, because the connective tissue loses elasticity. The upper airway muscles become less responsive and the airway gradually become more collapsible. In many patients, recurrence reflects the natural progression of the disease rather than failure of the original operation. Finally, not every patient fails because of anatomy. That's where the palm scale and the endotyping role comes. Some patients have high loop gain, others have a low arousal threshold. So the patient with the low arousal threshold, though the AHI improves, the patient's symptomatology may not improve because of the disturbed sleep which happens even with mild snoring which the patient is having. So those patients can be easily treated with medication and if needed physiotherapy or oromyofunctional therapy, etc. So that identification of this endotype is very important to understand why the failure happened, to understand what next step we are going to do. This we call it as physiological failure. For many years, sleep surgery was procedure driven. We look at the obstruction, remove it, clear it, but that's not now. A patient had OSA, we examine the palate and we select an operation, but now instead of asking which operation should I perform, we should ask, if we do surgery, where can we fail? So understand that part of failure is very important even before doing surgery, primary surgery for that patient. Once we identify the mechanism of failure, the treatment almost become obvious. That is the essence of precision sleep medicine. We are no longer operating on an airway. We are operating on an individual with unique phenotype and endotype. To achieve that, we should follow a structured protocol. That's where the integrated therapy comes. So I would say, to easy to remember, 5R revision protocol. That is, first recognize the symptoms persist and objectively confirm the residual disease via clinical screening and examination. Then re-evaluate, perform detailed diagnostic workup including PSG. Always go for level 1 PSG. DICE or dynamic MRI, yes, sometimes even both. Don't miss any investigation when you are looking at a revision case. Third, reclassify, identify how much is the anatomical component, how much is the physiological component of that patient. So most of the patients, 99% of the patients would have removed tonsils in these patients, a little bit of removal on the palate. So where the fail is happening, that's what you have to look at. And finally, revise the treatment modality, whether you are going to proceed with surgery or non-surgery. If surgery, whether it is going to be a soft tissue surgery or a skeletal surgery. And finally, don't miss this reassessment. Monitor the outcome using objective sleep studies, repeat PSG after 6 months, and patient reported sleep questionnaires. That's where POSQ, that in pediatric sleep questionnaires, and adult also OSA 18, etc. So you have to follow up the patient, make sure they are in good line, they are having a good sleep hygiene, they are doing physical exercise, maintaining the weight or weight reduction protocol all to be followed. All those has to be followed up. Unless we keep them on our follow up, the patient will come back with recurrence of symptom. So stage 1. The first stage looks very simple, but it is often missed, overlooked. Don't assume that every patient who complains of snoring has recurrent OSA. When did symptom recur? The patient might have been symptom free for past 3 months or 6 months or even maybe few years. My Professor Mohan Kameshan sir always says, just by chopping off the palate, you may be switching off the alarm which is ringing, and the patient may be still choking with tongue base collapse. That's where identification of multi-level obstruction is very important, and failing which, doing a single level surgical procedure may worsen the condition, but symptomatically he may not be having snoring because of we have removed the uvula and little bit of soft palate, but the symptoms will get worsened. So that we have to ask every bit of it. You have to spend little more time than your routine OSA initial evaluation. Has there been a weight gain? Is he doing his regular exercise? Is he on proper medication and diet restriction? Sometimes the history itself will tell us whether we are dealing with persistent disease or residual disease or recurrent disease. He may be having other sleep disorder like COMISA, insomnia with OSA. Both are interrelated, both has to be treated simultaneously, otherwise the patient will come back with residual disease like I am having still drowsy and sleepy in the daytime, I am not able to sleep at night. So identifying the clinical symptoms is very important. Next step is going to be evaluation. It's not a routine ENT examination. Again, from nose tip down to the level of vocal cord you have to see. Don't miss anything. Sometimes simple nasal valve may not be helping him to breathe comfortably through the nose. He may be having still nasal valve collapse. He may be mouth breathing. There may be dryness of mouth and scalloped margins of the tongue. So these are all shows that he is still having persistent mouth breathing, and it couldn't accommodate the tongue within the oral cavity. Is nasal obstruction preventing CPAP tolerance, or nasal obstruction is causing snoring? Simple inferior turbinate hypertrophy could have been the reason for his persistent snoring, though the AHA has become less than 5. The spouse will still say, my partner is still snoring. That is a failure on the aspect of patient, but you could have completely corrected the obstruction. So don't overlook any part of the clinical examination with diagnosed nasal endoscopy, video laryngoscopy. Look at the entire airway. keep in mind where we have failed, where the obstruction could be. Every millimeter increase in upper airway space will make the patient to breathe comfortably. So that's what we have to see, which contributed to the patient's current disease. I strongly believe that every revision patient deserves a repeat level 1 PSG. Lot of data are there in level 1 PSG, not just AHA alone. So there could be central apnea index, central apneas may be there, and hypoxic burden which we have to look for. What is the sleep duration? What is the REM phase? Whether he has sufficient REM duration is there. Is it REM dependent obstruction is happening? When you see the hypnogram, you will be able to understand whenever the REM phase is coming, he may be having choking and obstructive events. In those scenarios, you might have missed it in your routine DISE or dynamic MRI where we can't achieve what is happening during REM phase. So simple positional change might help him, or much more stronger physical exercise and improving oral muscle tone will help. So never plan revision surgery without a level 1 PSG or outdated sleep study. The patient may be going round, finally he will land up with you after 1 year with an old PSG. Don't go by that. So interpreting hypoxic burden is very important, and that will tell you, here you can see what is the difference between AHI and the hypoxic burden. The hypoxic burden is 42 here, and it's a poor response. These two patients are not biologically same, but their cardiovascular risk is very high. DISE. If I have to choose one investigation that has to be taken for the decision making, will be DISE. I personally believe no revision surgeries will be done without a DISE or a dynamic MRI. Awake examination tells us what the airway looks like, but DISE will tell us what the airway actually does during sleep. It always, most likely, you can see this patient, once you cross the palate, what you could see is only tongue based obstruction. See here, so this patient had already expansion sphincter pharyngoplasty elsewhere, and you can see the margin of the soft palate. There is no uvula has been removed. It is just approximating with the posterior pharyngeal wall, but once you cross that, what you could see is only tongue base. This patient is having pure tongue base collapse, which could have been missed in the primary assessment. Or else dynamic MRI, you can see here the cut end of the soft palate, which is nicely just touching the posterior pharyngeal wall. You can see a nice sagittal view here. Not only in sagittal view, axial view also you can get, reformatted view, you can have 3-dimensional reconstructive view, you can measure, you can also see the skeletal framework here. That's the biggest advantage of dynamic MRI compared to DISE. This gives you tongue volume, fat deposition, and how about tongue base? Is it lymphatic or tongue muscle hypertrophy? Here it is purely tongue muscle hypertrophy and hypotonia. It is falling back and causing obstruction. The palate is just moving, it is just approximating with the posterior pharyngeal wall, otherwise that soft palate will be hanging down further and blocking the passage. If we remove little more further, that will cause bilopharyngeal insufficiency. So dynamic MRI distinguishes anatomical limitation and from functional collapse, helping surgeons to select the most appropriate revision procedure and avoid unnecessary repeat surgery. Not just dynamic MRI and DISE, if you have the option, you should do cone beam CT to do an airway volume analysis. That will give you a lot of data where the more resistance is happening in all 3-dimensional way we can see. The strength lies in integrating them together, all possible investigative modality. Then you reclassify depending upon the phenotype and endotype sorting. The top layer, I would say, is selecting whether you are going to choose the patient for surgery or non-surgery. Non-surgery is, as I told you, weight management, medication, myofunctional therapy, etc. But when you are going to choose the patient for surgical modality for revision, then you have to, next step is to choose whether going to choose a skeletal procedure or a soft tissue surgery. When you choose soft tissue surgery, then you have to classify how much is the component of anatomical obstruction, and that is phenotype and endotype assessment. Every point importance matters when you are going to choose a revision procedure. Once we have understood the patient anatomy and the physiology, the next step becomes much easier. That's the where you have to involve the multidisciplinary team to take a final call or final decision. That's what Dr. Kishore was saying in the last few slides. So bring sleep physician, get his opinion about the repeat PSG, which we have missed anything, and involve maxillofacial surgeon, give him the cone beam CT and the patient, and ask him his opinion about is there anything we are missing on skeletal framework, and get other specialties, people like bariatric surgeon, myofunctional therapists, etc., and make sure you have left nothing. Finally, after this revision procedure may need orthodontic management to make sure the patient is closing his mouth. Sometimes even after all this procedure, if the patient is going to do mouth breathing, that's going to push the tongue further down and cause obstruction. That's going to cause as if looks like it will be a failure. So that's where the shared decision making and patient counseling is very important, not only in the primary surgery, it is very important when you are going to do a revision surgery. Establishing the realistic expectation. Don't tell that this second procedure is going to make you 100% disease free or snore free. That's not the way we are looking at the upper airway or OSA patient. Explain the failure and the complications. Risk has to be discussed. Highlight the increased complexity of the disease burden for that particular patient, and plan with them what is the expectation and what could be the outcome, what is the component of the patient and the family to do for further management. So the core principle is revision surgery is not about removing more tissue to create more space to restore functional stability. It's about restoring functional stability by preserving structures, not by removing structures. So the new way to look at this is identify the vector in which you have to pull or expand the upper airway space. So if the collapse is happening in the lateral wall, expand it laterally. If the collapse is happening in the anteroposterior direction, pull or do procedures which can expand the upper airway or the palate or tongue base anteriorly to create more space. Stabilize the framework and preserve the function and support the dynamic airway. So there are various options, and I am not going to go which surgical procedure is best for which, so you all know that. So we have to now revise the nasal surgery, or could be palatal surgery, tongue based surgery, skeletal surgery. So the various surgical procedures are there. That's not going to be much different than a primary procedure, but identification of which patient needs which procedure is the key. Ultimate rescue, tracheostomy. Sometimes, fortunately or unfortunately, tracheostomy has become uncommon in modern sleep surgery, but still it holds its value. The patient who may be much more comfortable to do a tracheostomy to manage during daytime, and he can comfortably open up and sleep. We have a couple of patients whom we have done many years back who are still comfortable with sleeping with open tracheostomy at night and keeping his tracheostomy closed in the daytime, and he leads a comfortable life. So here also understanding by the patients and his family is very important. Nevertheless, complication is also to be kept in mind when you are managing these patients. It's not only for the surgeons, anesthetist also. So previous surgery would have created a lot of scar, distorted anatomy, making airway much more challenging. So careful preoperative planning with awake fiber optic techniques may be needed in these patients for intubation. So safe revision surgery begins long before the surgery. Next step, the last one is reassess the outcome of revision surgery and keep them under follow-up. Meaningful improvement in quality of life remains the ultimate goal of revision intervention. It is not just AHI reduction alone. Sometimes we may have to keep the patient on CPAP also. That's where the multidisciplinary team helps. So till now whatever we have discussed is more of theoretical. Let me now take you through a scenario who recently operated. So how we are taking this decision in this patient. So here is a 42-year-old female with a BMI of 31 with recurrent loud snoring and nocturnal choking 2 years after isolated palatal surgery, not much details. She was put on CPAP. She is not able to tolerate due to high pressure. The pressure is around, Pmax is around 15 to 16, though it is acceptable, but she couldn't tolerate. And the symptoms recurred within 6 months of primary surgery. So the workflow will be detailed clinical history to make sure there is no other sleep disorder, including the history of recent weight gain. She is doing exercise. There is no change in weight, sedentary lifestyle, but she is a hypertension and hypothyroid. And we did level 1 PSG, showed I think it is around still 30. Cone beam CT and dynamic MRI both has been done for anatomical mapping. DICE identified collapse at the level of, I will show the DICE video. And finally, a multidisciplinary team discussion was done to plan the treatment. PSG showed 38 events per hour. It is moderate to severe OSA with persistent obstructive events. ODA was 34. Lowest saturation was around 78. Supine AHI was little higher, 52. That indirectly indicates could be a tongue-based involvement, and ESS was 14. This data confirms severe OSA that cannot be managed by conservative measures, obvious. So we have done cone beam CT, structural analysis done, significant inferior turbinate hypertrophy was there, retropalatal and retroglossal collapse was there. There was no major skeletal deficiency or craniofacial anomaly. Dynamic MRI showed large tongue volume with significant lateral wall collapse at velum that worsens during respiratory cycle, that's during apnea. In DICE we could see not just lateral wall collapse, you can see, sorry. So you can see here how the lateral wall is collapsing and the posterior part of the border of the velum is not touching the posterior ventral, just approximating but still having snoring. So when you look down further, you can see here how redundant the hypopharyngeal mucosa, so aryepiglottic fold, arytenoid. So this was missed in dynamic MRI, maybe in the previous assessment also. So after discussion with the multidisciplinary team, we have proceeded with, after detailed discussion and counseling, that patient may need CPAP after the surgery. We have proceeded with inferior turbinoplasty, barb lateral pharyngoplasty and tongue base reduction with epiglottopexy. So here you can see the cut end of the palate, no uvula, no tonsils. See, when you are doing this procedure, you have to keep in mind the dice. What, where was the obstruction? This was happening at the level of lateral wall, especially near the lower velum. It was little further down than the level of the border of the palate. So you may have to go little more higher. So there we have made the surface raw and we have divided and expanded that area much more laterally towards the pterygomandibular raphe with barbed suture. The surgery is not yet shaking, and it's going to be very simple. With barbed sutures, we pull down all this soft tissue laterally and also stiffen the palate with barbed suture, so to stabilize the upper airway without much resection of tissue. That widens and stabilizes the upper airway in that dimension. Most important thing which was missed in the previous procedure was about the hypopharyngeal collapse, like how Dr. Kishore showed for a laryngomalacia. These are redundant mucosa which can collapse into the upper airway when the patient has a deep inspiration. So stiffen this mucosa with the EVAC 70 wand only I am using, not laser, and all this redundant mucosa is being ablated. This will scarify in few weeks and prevent collapse. Simple procedures, but this has been the reason for even CPAP intolerance, because when you put the CPAP mask, this puts more pressure and further obstructs the passage, and also tongue base excision also being done. So post-operatively, we have suggested her myofunctional therapy, weight reduction management, and sleep hygiene, and advise them regular follow-up. So never perform revision surgery without understanding why the primary surgery failed. Reassess the patient comprehensively. Evaluate the underlying cause of failure rather than just the site of obstruction. DICE is the cornerstone of modern revision surgical planning. Individualize the treatment according to the anatomical and physiological, that's phenotypic and endotypic characteristics. Select the functional airway reconstruction rather than just excising the tissue and opening up the airway is not the goal. So integrate surgical and non-surgical therapies through multidisciplinary care. Involve the multidisciplinary team. Optimize the surgical technique while preserving normal anatomy and function. Navigate them, don't leave them after the surgery. Follow them up using objective outcome measures, not just post-op PSG. Thank you.
Very excellent talk and detailed talk about revision surgery in OSA. As a sleep surgery expert, you're doing a lot of surgeries. So what are the percentage of second surgeries in your series, and what are the reasons you have found? What are the reasons for which you have done revision surgeries?
Revision surgeries. That's where my main criteria for selecting the patient for surgery is BMI. Obesity is one of the most prime factor which can fail the procedure what you have done. So my selection of patient for surgery itself will be around 10 to 20% or 10% maybe. So the remaining patients will be managed with CPAP and other modalities, not just CPAP alone. In that, choosing the right patient with multi-level procedure or single-level procedure according to the patient need, your surgical success rate can be about 90%, 85 to 90% for properly selecting the right patient. That's the very key important word. Otherwise, if you are going to operate for more patients, you have to face more patients for revisions. The revision cases are, as I told you, complex cases. We have to understand the physiology behind the failure. You all should not always look at them as surgical failure. That's a key message which I would like to pass it on.
Okay, thank you.
Thank you, sir.
Thank you, Vijay. It was a pleasure chairing your
Thank
section.
you.
Because being a friend, I have been seeing you for a long time, growing to a big height, and you have reached adorable place in ENT.
Thank
And
you.
my heartfelt wishes for that, Vijay.
Thank you.
One more doubt, sir. Have you ever seen any residual tonsillar tissue in doing this revision surgeries? Because the remnant tonsil beneath that pillars sometimes goes in for hypertrophy and
Yeah, that can happen. You see, now many are afraid of removing the tonsillar tissue near the inferior pole. So if you leave that tonsillar tissue, or if you have that can also hypertrophy later. We always see, I have actually one video, we always say tongue base is always have anteroposterior collapse. Sometimes this kind of lingual tonsil hypertrophy and lateral that's tonsillar tissue remnant can cause a kind of a lateral collapse at the level of tongue base. So that is commonly seen.
most commonly incomplete.
Most commonly if it is incomplete removal of tonsil. Because see, practically speaking, when you do the tonsillectomy in these patients with a difficult opening and huge tongue base with a high BMI, the tongue blade, if you have not chosen properly, that itself will not give you or show you the inferior pole clearly.
The zetaplasty sometimes
Yes,
we approximate
yes.
the pillars. Sometimes the residual tonsil
Tissue.
goes beneath that.
Yes, that can happen. So, thank you, ma'am.
Okay, one more question. Is there any case in which we prioritize DICE over dynamic MRI? Is there any case in which you couldn't do a DICE to diagnose it in a very severe obese patients or something?
Not only obese patients, see, DICE, we commonly use dexmedetomidine, which can cause bradycardia and hypotension. So those patients who have this kind of issues, or those who are on beta blockers, we have to do it very cautiously, diagnosis DICE. In those patients, sometimes we may underestimate because of using less medication, so that we are over cautious not to cause them. In those patients, we may miss tongue base collapse or epiglottic collapse like that. So in those patients, definitely dynamic MRI will also help if he could sleep comfortably with the protocol what we follow and what we have instructed to the radiographer. He'll be able to get a proper image reconstruction of the airway.
Thank you, Vijay.
Last question.
Yes, sir.
Is there any thing you plan for a second stage procedure also? The patient do in a multi-stage procedure. First stage do this, second stage do that.
See, usually revision surgeries are single stage, multi-level, or else it will be a combination of soft tissue and skeletal procedure together. Single procedure alone may not be that common, or I have not done in the case scenarios of what I have done for the revision cases, I mean. So always will be a multi-level surgery.
Thank you.
And you have to remember, these patients have already with mental trauma and physical trauma. So asking them to come for various stage procedures may be really difficult. Thank you.
Thank you, Vijay.
Thank you, sir.